guys have already schedule, but unfortunately, we looked at the amount of data and presentation that we had to put forth, and thought that we'll have a separate session for ARDS itself. So we'll be planning that class as a separate class. We thought respiratory itself needs two classes, but despite us planning it out, we thought it is not going to be justified to do ARDS in 1 hour and give you guys an incomplete picture. So we are going to start with pulmonary embolism, but rest assured, we are going to have a class on ARDS in the coming week, details of which will be posted in the group for you guys. Okay. So I'll hand over the proceedings to Dr. Niharika to start with the pulmonary embolism. I think
okay,
so.
Darshan. Yeah.
Thank you.
So good evening all. So the first topic for today's session is pulmonary embolism. As we all know, pulmonary embolism is a major case for practical exams, but coming to your theory exams, not many questions have been asked in the previous year exit exams. But since the incidence of the PE is increasing in the past few years, especially in the post-COVID era, so we can expect actually some theory questions in the upcoming years. So without delaying much, we'll further start the topic. So my outline of the topic would be introduction, predisposing factors, the pathophysiology, clinical presentation, pretest probability, investigations, treatment, and a small note on PE in pregnancy and CTEPH. So coming to your previous year examinations, there was actually once in FNB, I think it's 2016 or 2017, they've asked about the diagnosis and management of pulmonary embolism. So coming to the introduction. So what is the definition of pulmonary embolism? It is nothing but a thrombus in the either main pulmonary artery or at the bifurcation or in the lobar branches of the pulmonary artery. So what are the sources of this thrombus? It could be from the deep vein system of the lower extremities, which is the most common source, around 85%, followed by pelvic, renal, upper extremity veins, and the right heart chambers. Coming to the epidemiology. So this venous thromboembolism usually or clinically presents as DVT or pulmonary embolism. It is the third most frequent acute cardiovascular syndrome after MI and stroke. Coming to the incident rates, for acute PE, it is 40 to 150 per 1 lakh population. And for DVT, it is around 50 to 160 per 1 lakh population. And the incidence almost is 8 times higher in individuals aged more than 80 years. So coming to the predisposing factors, so the recent guidelines on pulmonary embolism was given by the European Society in 2019, and they have classified the predisposing factors into strong risk factors, moderate risk factors, and weak risk factors. Coming to strong risk factors, these include any fracture of the lower limb, hospitalization for heart failure or any AF in the previous 3 months, hip or knee replacement, major trauma, MI within the previous 3 months, previous episode of VTE, or any spinal cord injury. Coming to the moderate risk factors, the important ones includes arthroscopic knee surgery, blood transfusion, any lines like central venous line or any intravenous catheters and leads, post-chemo, then erythropoiesis stimulating agents, OC pills, hormone replacement therapy, and others. Coming to the weak risk factors, bed rest for more than three days, underlying diabetes mellitus, arterial hypertension, immobility due to sitting, that is prolonged car or air travel, any increasing age, laparoscopic surgery, obesity, pregnancy, and varicose veins. Coming to the pathophysiology. So the major pathophysiological contribution or the cause to pulmonary embolism is because of the virtuous triad. So any conditions leading to virtuous triad may cause pulmonary embolism. The other cause could be any prothrombotic states. And the third could be embolization. So coming to the causes of so as we know, virtuous triad is nothing but the hypercoagulable state, any vascular wall injury or circulatory stasis. So these causes might lead to the formation of lead to cause pulmonary embolism. So As we all know, hypercoagulable state malignancy is the most common cause. Estrogen therapy, trauma, or sepsis, vascular injury, any venipuncture, chemical irritation, heart valve disease or replacement or indwelling catheters, and circulatory stasis could be due to immobility, LV dysfunction, AF, venous insufficiency, or varicose veins. Now, coming to the prothrombotic states, these could be divided into the congenital and the acquired causes. The most common congenital causes are protein C and S deficiency, factor V leading mutation, homocystinemia, antithrombin 3 deficiency. And in acquired, the causes could be APLA, pregnancy, sickle cell anemia, trauma, myeloproliferative disorders, OCPLs. So, what is the main pathophysiological mechanism? That acute PE interferes with both the circulatory system as well as the respiratory system, that is a gas exchange. So, RV failure due to acute pressure overload is considered as the primary cause of death in severe PE. And usually the pulmonary artery pressure increases if there is more than 30 to 50% of the total cross-sectional area of the pulmonary arterial blood which is occluded by the thromboembolism. So these are the cardiopulmonary effects of pulmonary embolism. So if they ask about the pathophysiology for you, you have to write about the virtuous triad, the causes for the thrombophilia's causes, and then this flow chart. So what happens if there is an occlusion of the pulmonary artery? There will be an increased RV afterload. This leads to increase in the RV pressure, which causes three important things. What is those? One is it increases the myocardial oxygen demand, leading to RV ischemia. It causes RV dilatation, leading to some neurohormonal activation, which leads to reduced RV contractility. As a result, the RV stroke volume is reduced. And this RV stroke volume reduction leads to reduced LV preload, leading to decreased cardiac output and the systemic blood pressure, which further leads to reduced coronary perfusion, leading to RV ischemia. And the third effect is there will be increased PR. Also, the occlusion of the pulmonary arteries may lead to pulmonary AV shunting, leading to the respiratory effect, that is the hypoxia, and this hypoxia further leads to RV ischemia. So coming to the physiological changes which occurs in PE is that, so as I told, there will be vascular obstruction and platelet secretion of neurohormonal agents like serotonin, which may lead to increased pulmonary vascular resistance. Due to impaired gas exchange, there is hypoxemia. Due to increased physiological dead space ventilation, there is an increased AA gradient. And due to alveolar hyperventilation, there could be an initial hypocapnia in the ABG. So now coming to the signs and symptoms of PE. So the patient usually presents with chest pain, shortness of breath, cough, in some cases hemoptysis, and syncope in case of hemodynamic instability. What could be the signs? There could be tachycardia, tachypnea, any signs of DVT, raised JVP, fever, and cyanosis. So hemodynamic instability is an important factor to know about the prognosis of the disease. So how is it defined, or how this hemodynamic instability can be manifested? So it can be manifested in three forms. One is this hemodynamic instability can occur as a cardiac arrest. Second one is the obstructive shock. And the third one is the persistent hypotension. So cardiac arrest means there is a need for CPR. Obstructive shock presents as a systolic blood pressure of less than 90 mmHg, or vasopressors which are required to achieve a BP of more than or equal to 90 mmHg despite adequate filling status. Plus, there should be an end organ hypoperfusion. This is the definition of obstructive shock. Now, what is persistent shock? It is nothing but the systolic BP of less than 90 mmHg, or a drop in systolic BP of more than or equal to 40 mmHg, which lasts longer than 15 minutes and is not caused by any other causes like new onset arrhythmias, hypovolemia, or sepsis. Okay, so this is the definition of hemodynamic instability in PE. Now coming to the assessment of clinical probability or the pretest probability assessment. So basically, this pretest probability includes combination of symptoms, clinical findings, and presence of predisposing factors for the VTE. So this assessment can be done by two methods. One is the clinical judgment, and the second one is by using the prediction rules. This clinical judgment means it includes by seeing the chest x-rays, ECGs, echoes. But the thing is, it lacks standardization. So the best way to predict the probability is by using the prediction rules, that is the revised Geneva rule and the Wells rule. Coming to the revised Geneva clinical prediction rule. So basically it contains around 8 components. Okay, I think the original version has been made a easier way simplified version where each component carries 1 point except the heart rate of more than or equal to 95, which has the 2-point contribution. So to know the clinical probability, it is divided into 3-level score and the 2-level score. So better to use a 2-level score because it is an easy way of understanding and assessing. So if the score is 0 to 2, then PE is unlikely. If the score is greater than or equal to 3, it is PE likely. So coming to the probability chances, if there is a low probability category, so there is a chances of 10% risk of PE occurrence. If it is moderate probability, it is 30%. If it is high probability category, then 65% of patients may have PE. Coming to the 2-level score, if PE is unlikely, then there is 12% chance of occurrence of PE. And if it is PE likely category, it is 30% chance. Now coming to the Wells score. So Wells score also contains the same components as of Geneva score, except the age. The age factor is not here. So this also has an original version and the simplified version. And same, the clinical probability scorings are also divided as a 3-level and 2-level scorings. So you can actually remember one score. I think revised Geneva would be a preferred one. Now, since the incidence is increasing and a lot of those people who are presenting with any one of the risk factors, and either they have hypoxemia or hemodynamic instability, many patients think that it could be PE and they expose the patient to a lot of radiation for CTPA and all. So you have to actually avoid the overuse of diagnostic tests for PE. So what happens in the ER department, they use something known as the PERC criteria. What is this PERC criteria? It is pulmonary embolism rule out criteria. Okay, so what components that this PERC has? If the age is less than 50, heart rate is less than 100, and SaO2 is more than or equal to 95% on room air, and if the patient doesn't have any of these, like there is no history of recent trauma or surgery, no prior DVT or PE, no unilateral leg swelling, no exogenous estrogen therapy, or no hemoptysis, then the chances of this patient having a pulmonary embolism is less. So need not to make the patient to undergo a lot of tests, especially this CTPA, which has a lot of radiation exposure. Now coming to the investigations that are performed in case of a PE. So first and foremost, we do is an ABG. So what are the ABG features of pulmonary embolism? So as we know, it is hypoxemia and there is hypocapnia because of alveolar hyperventilation, which leads to respiratory alkalosis. Just a minute. Sorry for the delay. So ABG shows the evidence of hypoxemia, hypocapnia, respiratory alkalosis, and if there is a massive pulmonary embolism, then there would be alveolar hypoventilation, which leads to hypercapnia or a mixed respiratory and metabolic acidosis, and there is increased AA gradient due to increased physiological dead space. Now coming to the ECG changes. So I think we all think of two important ECG changes, that is one sinus tachycardia or S1Q3T3 pattern. So sinus tachycardia usually occurs in mild cases and it is seen in around 40%. There could be some non-specific STT changes, and this S1Q3T3 pattern is seen from 10 to 50% of patients. And important is the RV strain pattern, which is nothing but the inversion of the T waves in leads V1 to V4 and a QR pattern in V1. And in severe cases, there could be an incomplete or a complete RBBP. And atrial arrhythmias, the most common one includes atrial fibrillation. So now coming to the D-dimer. So D-dimer is elevated in PE due to simultaneous activation of coagulation as well as fibrinolysis. The importance of D-dimer is that it has a high negative predictive value than the positive predictive value. Okay, so if the values are normal, then PE is unlikely. Okay, so we usually do a quantitative ELISA test for to know the values of the D-dimer. So as I told, a negative ELISA D-dimer plus low or intermediate clinical probability, then we can exclude the disease without further testing. The standard cutoff value is 500 nanogram per ml. The thing we should understand is as the age increases, especially above 80 years, the specificity of the D-dimer actually decreases by around 10% as the age precedes more than 80 years. So for patients aged more than 50 years, we have something age adjusted cutoff values for D-dimers, which is calculated as age into 10 microgram per liter. Then coming to the D-dimer cutoffs, which is adapted to clinical probability, which is known as Years algorithm. So what is this Years algorithm? So basically you do a D-dimer test and you look for 3 components. Okay, those are known as Years items. So what are those? Any clinical signs of DVT, any hemoptysis, and you think that T is the most likely diagnosis. Okay, then you have 4 scenarios. One is there is 0 Years items, but the D-dimer levels are less than 1000. So you can exclude the PE. But important thing is when there is 0 Years items, but the D-dimer is more than 1000, then you think that the chances of PE is likely in these patients and you have to order for a CTPA. Okay. The other thing is the D-dimer levels, which are 500. Okay. So if you feel that there are any 1 to 3 Years items plus the D-dimer levels are less than 500, here also you can exclude the PE. But if there is 1 to 3 year items plus the D-dimer levels of more than 500 or more than 500, then you have to think it could be a PE and order a CTPA. So these two are the important components of the Years algorithm. Now coming to the other biomarkers. So the other 2 important biomarkers are one are the troponins, one are the natriuretic peptides. So BNP, it is basically the marker of RV dysfunction. So why the BNP level increases? In acute PE, there is RV pressure overload, which leads to increased myocardial stretch, leading to the release of the BNP and the NT-proBNP. So basically the plasma levels of natriuretic peptides, they reflect the severity of RV dysfunction and the hemodynamic compromise. The cutoffs are less than 500 picogram per ml, and it is used as a prognostic marker. Troponins, they are also used as a prognostic marker and is a marker of myocardial injury. So the abrupt increase in RV wall tension leads to the compression of the right coronary artery and direct myocardial microinjury, leading to increased troponin levels. So the elevated plasma troponin concentration on admission may be associated with a worse prognosis in the acute phase of PE. So the next one is chest X-ray. So around 30% of patient has a normal chest X-ray, but the others might have a lot of signs on the chest X-ray. So important being the Hampton's hump and the Western mark sign. So Hampton's hump, I think everyone knows about that. It is nothing but a dome-shaped pleural-based opacification, okay, which represents the hemorrhage and necrotic lung tissue in the region of the pulmonary infarct. Whereas Westermarck sign is basically the oligamia. There's a focal oligamia of the lung markings. So the other one, Flesher sign, knuckle sign, Palla sign, Chang sign, and pleural effusion. You can go through, and if you know anything, please just mention in the chat box if you know what are these signs for. And the important thing which we all do in the bedside is the 2D echo. So what are the 2D echo signs that we have to know in PE? The first one is, especially in the parasternal long axis view, we can see the enlarged right ventricle. The second one, in the four chamber view, we can see two things. One is there is dilated RV with the basal RV by LV ratio of more than 1 and the McConnell sign. So McConnell sign is nothing but the RV free wall akinesia with sparing of the apex. The third one is the parasternal short axis view, where you can see that there is a flattened intraventricular septum leading to a D-shaped ventricle, D-shaped LV. And in the subcostal view, you can see that the IVC is distended and there is diminished inspiratory collapsibility. The other signs include the 60-60 sign. So in the 60-60 sign, we see two things. One is the pulmonary acceleration time, that is known as PAT. Okay, the normal value being 135 to 150 milliseconds. In pulmonary embolism, it is less than 60 milliseconds. And the second one which we measure is the TR jet gradient, okay, which is less than 60 mmHg in pulmonary embolism. This sign has a high specificity but low sensitivity. So this sign you can get in a parasternal short axis view in the pulse wave Doppler. Next, if you see the most sensitive, the most specific sign is if you see a right heart mobile thrombus. Okay, and next one is the TAPC, which we all measure in the bedside. So we know that the TAPC less than 16 mmHg has a more specific sign for pulmonary embolism. So TAPC is usually measured in the apical four chamber view in the M mode. Next, coming to the tissue Doppler imaging, there is a decreased peak systolic velocity of the tricuspid annulus of less than 9.5 centimeters per second. So these are the echo findings which we see in pulmonary embolism. And as I told, the most specific is seeing a mobile thrombus. Now coming to the advantages of the echo. So as there are a lot of specific signs, it has a high predictive value, positive predictive value. And it can be done in an unstable patient. So you can actually rule out PE with signs of any RV dysfunction. And also you can rule out other causes of hypotension, like if there is a cardiac tamponade, valvular dysfunction, hypovolemia, or any dissection. But what are the disadvantages is that it has a weak negative predictive value if there are no signs of PE in the echo. Also, this RV overload can also occur due to other cardiorespiratory diseases. So that is one of the disadvantages of performing in bedside echo. So coming to the CT pulmonary angiography. So this is the method of choice for imaging the pulmonary vasculature in patients with suspected PE. So it helps in visualization of the main pulmonary arteries. Also, till the subsegmental levels also we can see the pulmonary arteries. What are the strengths of CTPA? Basically, it is readily available round the clock. It has excellent accuracy, may provide alternative diagnosis if PE is excluded, and it has a short acquisition time. But the major limitation is the radiation exposure. Okay, the effective radiation dose is around 3 to 10 millisievert. Okay, the other thing is exposure to the contrast. Okay, so some patients will be having iodine allergy, hyperthyroidism, or patient could be pregnant or breastfeeding woman, or renal failure. In all these cases, the iodinated contrast is contraindicated. So these are the limitations of the CTPA. So the effect of CTPA in PE diagnosis actually was proposed by this. It has become the choice after this PIOPET-2 study. So it is nothing but the prospective investigation on pulmonary embolism diagnosis study, which had observed a sensitivity of around 83% and a specificity of around 96% for CTPA in PE diagnosis. Also, it has a negative predictive value also of around 96 to 89%. To exclude PE in low and intermediate probability risk patients. So this is the CTPA. So this figure is showing that there is a right segmental thrombus here, left distal pulmonary artery thrombus, and this, as we all know, this is a saddle thrombus. Now the other scan is the VQ scan or the lung scintigraphy. So we have two types of VQ scans. One is the planar VQ scan and one is the VQ SPECT scan. So basically what is the advantage of the scan is there is almost no contraindications in doing this scan and it is relatively inexpensive. But the problem is the limitation is that it is not readily available in all centers. And it is actually the best scan to be performed in cases of CTEPH. And it has a lower radiation than the CTPA. That is one more advantages of performing the VQ scan. So this is in detail about the VQ scan. Basically, it has two phases, perfusion phase and the ventilation phase. And you inject uh, different traces or the radioactive materials into it, and then you perform it. As I told, there is no contraindications in renal failure or even in pregnancy also. So the results actually come as matched and mismatched. What is matched? There is ventilation as well as a perfusion defect, which is seen usually in parenchymal diseases. But what is mismatched means the perfusion is reduced, but the ventilation is normal. So that is usually seen in pulmonary embolism. Now coming to the pulmonary angiography, which was actually a historical gold standard test. But the main limitations of this test are it is an invasive procedure and it is not readily available in all the centers and it has the highest radiation. The effective dose is around 10 to 20 millisievert. So coming to MRI, so in patients who are not able to be performed CTPA and who are hemodynamically stable and you want to rule out PE, so it helps in the visualization of the pulmonary, it helps to see if the pulmonary perfusion is reduced, delayed, or there is an absent blood flow. And the last one is the important one, the Doppler of lower limb, that is the compression ultrasound. So basically, we see the compressibility of the deep vein system or any presence of echogenic material, and it has both high sensitivity and specificity also. Now, these are about the investigations that are performed in pulmonary embolism. Coming to the severity assessment of pulmonary embolism. So this can be done by a PESI score, that is a pulmonary embolism severity index score. So basically it has three major components like demographic characteristics, comorbid illnesses, and clinical findings. And these are the points which has been given. And in each category, the score has been attributed into 5 categories and each has a 30-day different 30-day mortality. The class 1 being around 1.1% of 30-day mortality, whereas the class 5 being 24.5% 30-day mortality. So this PESI score has been simplified, okay, having only around 6 components and each component carries a single a single value for the component. Now this is very important thing. Classification of PE severity and the risk of early in-hospital or 30-day death. So we have seen all these things. We have seen the clinical features, we have seen the PESI score, we have seen all the lab investigations and the biomarkers. So taking all these into one thing, we are going to risk the severity of the PE. So it has been risked into high risk category, intermediate risk category, and the low risk category. So in intermediate, we have again two, intermediate high and intermediate low risk category. So this you should keep in mind. So in high risk category, there will be hemodynamic instability. There will be, the PESI score will be very high, that is either class 3 to 5. And there is evidence of RV dysfunction either on transthoracic echo or a CTPA, and there are elevated biomarkers, especially the troponin levels. So when all these are present, then it is known as high risk PE. Okay, coming to the intermediate. So in intermediate, we have intermediate high risk. Okay, everything is present, but there is no evidence of hemodynamic instability. Whereas in intermediate low, there is presence of PC class 3 to 4, but either there could be an RV dysfunction or either there could be an elevated troponin levels and there is no hemodynamic instability here. Whereas in low risk category, most of them are negative. Okay, this has to be kept in mind because the further slides actually goes with this. What happens in high, what is the treatment, how do you evaluate? Okay. Okay, so this is how you perform the diagnostic tests in case of PE. Suppose if the patient is a suspected PE without any hemodynamic instability, then you basically assess the clinical probability, okay, whether the patient is in high risk, intermediate risk, or low risk. Okay, so if the patient is in low or intermediate clinical probability or PE unlikely, you do a D-dimer test. So if the D-dimer test is negative, then no treatment is required. D-dimer negative and there is a low to intermediate probability, no treatment. But patient has a low to intermediate clinical probability with a high D-dimer values, then you have to do a CTPA and then decide about the treatment. If there is no PE here, treatment is not required. If PE is confirmed, then treatment is required. But if there is a high clinical probability, then you have to directly go to a CTPA. There is no role of D-dimer in case of high clinical probability. Okay, so directly do a CTPA and then if there is a confirmed PE, you do the treatment. Okay, this is in patients without hemodynamic instability. Now, how do you go about a patient with a hemodynamic instability? So with hemodynamic instability, so first the best test would be performing a transthoracic echo and see if there are any signs of RV dysfunctions. If there are no signs, you have to search the other causes of this hemodynamic instability. If there is an RV dysfunction, then if there is a possibility to do a CTPA, you do it. And then if there is a confirmed PA, you treat it. But if there is no possibility of CTPA, but there is an RV dysfunction, please treat this patient as a high-risk PE and do the further management. Okay, and in this hemodynamic instability, there is no role of your D-dimer here also. So it is only in low to probable hemodynamically stable patient that you can do your D-dimers. Now this you can go through. We have actually shared you this article of 2019 ESC recommendations. You can go through it. Now coming to the treatment of pulmonary embolism, very important. So it is broadly divided into three. One is hemodynamic and respiratory support. Second one is the anticoagulation. Third one is the reperfusion therapy. So coming to the hemodynamic and respiratory support. So supplemental oxygen is indicated in patients with PE and SaO2 of less than 90%. Otherwise, no supplemental oxygen is required. So this can be provided either through HFNC or NIV and in rare situations, invasive ventilation. But what are the side effects of invasive ventilation is that the positive intrathoracic pressure may lead to decreased venous return, leading to worsening of the hemodynamic parameters in RV failure patients. Hence, it has to be used with caution. And if it is invasive ventilation, as we know, it is a lung protective ventilation that has been used. Coming to the pharmacological treatment of acute RV failure, it will be even discussed in cardiology module. So first one would be the volume optimization. So cautious fluid volume loading has to be done in these patients. Second, you can use either norepinephrine or dobutamine. And the third is the mechanical circulatory support in the form of VA ECMO can be done. So this temporary use of VA ECMO will be done in patients with high risk PE and circulatory collapse or a cardiac arrest. Coming to the CPR. So CPR should be continued for at least 60 to 90 minutes before terminating resuscitation attempts in case of PE. So you require a longer time of CPR in PE, suspected PE patients. And even if there is a cardiac arrest and if you have a high suspicion of PE, please give the thrombolytic agent. I will discuss about the dose later. Now, second is the anticoagulation. So the anticoagulation in the initial stages, we usually give with unfractionated heparin or low molecular weight heparin. So unfractionated heparin is basically restricted to patients with overt hemodynamic instability or imminent hemodynamic decompensation in whom primary reperfusion treatment will be necessary in the next few hours. Second one is if there is an underlying renal impairment, the creatinine clearance is less than 30 ml per minute, then unfractionated heparin would be a better choice. And in patients with severe obesity. And fondaparinux, basically it has a lower risk of inducing major bleeding, and it is also used in heparin-induced thrombocytopenia. The advantage is that no routine monitoring of anti-10A levels are required for fondaparinux. So coming to the doses of the same. So enoxaparin, as we know, it is 1 mg per kg BD or 1.5 mg per kg OD dose. And next we would use this deltaparin, which is 100 international unit per kg BD or 200 international unit per kg OD. And fondaparinox is depending upon the body weight. And unfractionated heparin, last time as we discussed, it is monitored with the APTT levels as an infusion. Now, this is in the acute phase. After the acute phase, you can actually shift the patient onto either Novax or vitamin K antagonists. So, what are the Novax that are used here? We can use all the 4 available Novax, the apixaban, dabigatran, edoxaban, and rivaroxaban. So, you can later go on through all these things. What is the half-life, renal elimination? But the thing is, dabigatran is factor 2A inhibitor, whereas the other 3 are factor 10A inhibitors. And the renal clear, dabigatran is actually excreted renally about 80%. Renal elimination is around 80%. Okay, and you should know about the reversal agents which are preferred for each of them. Now, these are the trials of Novax in VTE. So if you have time for the theory, I don't think they would ask much, but for the practical, you should know at least the names of the trials, Novax trials which are used in VTE for the Novax. So dabigatran, you have the recover trial. For rivaroxaban, it is the Anstin DVT and Anstin PE trial. For apixaban, it is amplified trial. And for edoxaban, it is Hokusai VTE trial. You can go through it later when you have time. Coming to the vitamin K antagonists. So when we use this vitamin K antagonists, we have to anticoagulate them in combination with unfractionated heparin, low molecular or fondaparinux until 5 days, or the INR value lies between 2 to 3 for the 2 consecutive days. So these two should be used in parallel. So dose of warfarin that has to be started is, for a younger patient, you can start with 10 mg, but for the older patients, better to start with less than 5 mg. And the daily dose is adjusted accordingly to the INR over the next 5 to 7 days, aiming for an INR level, as I told, it is 2 to 3. So this is about the anticoagulation. And the other one, the last one, is the reperfusion treatment. So in this, you have the systemic thrombolysis, we have the percutaneous catheter-directed thrombolysis, and the third one is the surgical thrombectomy. So coming to the systemic thrombolysis. So systemic thrombolysis is usually advised in high-risk PE patients. So as I told, high risk is all those, they fill all the 4 major criteria of hemodynamic instability, RV dysfunction, PESI score 3 to 5, and elevated troponin levels. Okay, so basically it is hemodynamic instability in an easy way to understand. So systemic thrombolytic therapy leads to faster improvements in pulmonary obstruction, increased in PAP, and compared to the unfractionated heparin alone. So these improvements are accompanied by a reduction in RV dilatation on echocardiography. The greatest benefit is observed when it is initiated within 48 hours of symptom onset, but it can still be useful until 6 to 14 days of patient experiencing the symptoms. So we have 3 important drugs, but the most common or the approved drug is the Altiplase, which is given as 10 mg over 2 hours. And streptokinase, 2.5 lakh units as a loading dose over 30 minutes, followed by 1 lakh over the next 12 to 24 hours. And urokinase, I think no one will be using the urokinase now. So there is something known as accelerated regimes. What are these accelerated regimes? As I told, in case of patient having a cardiac arrest and you suspect there is a high chances of PE in this patient, so you can't give a streptokinase dose or altiplase dose over 2 hours or over 24 hours, right? So accelerated regime is for a shorter duration of time. So in patients having a cardiac arrest, you can give altiplase of 0.6 mg per kg over 15 minutes, maximum of 50 mg. And streptokinase, it is 1.5 million international unit over 2 hours. And you should know the contraindications for fibrinosis, the absolute and the relatives. Second one is percutaneous catheter directed treatment. So here the mechanical reperfusion is based on the insertion of catheter into the pulmonary arteries via the femoral route. And what are the types of percutaneous catheter directed treatment? One is, as I told, catheter directed thrombolysis. Second one is ultrasound assisted catheter directed thrombolysis. Third one is rheolytic thrombectomy plus catheter direct thrombolysis, or the combination of the above three. Coming to the surgical thrombectomy. So basically surgical thrombectomy is carried with a cardiopulmonary bypass, but there would be no aortic cross clamping and cardioplegic cardiac arrest. And basically you do incision of the two main arteries and then remove or suction the fresh clots. So coming to the recommendations of these treatments. So coming to the class 1 evidence. So class 1 evidence tell that anticoagulation with unfractionated heparin be initiated without delay in patients with high risk PE. That every one of us does that. Second, systemic thrombolytic therapy is recommended for high risk PE. Yes, that we do. The other one is, when do we use the surgical pulmonary embolectomy? It is recommended for patients with high risk PE in whom thrombolysis is contraindicated or it has been failed. But this is a class 1 evidence. Coming to the percutaneous catheter direct treatment is a class 2A evidence. Same, the indication is the same when the thrombolysis is contraindicated or failed. So better to use class 1 evidence would be better for a surgical pulmonary thrombectomy and followed by a percutaneous catheter directed treatment. Now, coming to something known as multidisciplinary pulmonary embolism teams. So this concept have been emerged first in the USA. So what is this PERT? PERT is nothing but Pulmonary Embolism Rapid Response Team. Okay. So basically it brings together a team of specialists from different disciplines like cardiology, pulmonology, hematology, vascular medicine, intensivists or anesthesiologists, cardiothoracic surgeon, and even the interventional radiology. So what they do is, the team conveys in the real-time face-to-face to enhance clinical decision making and also to formulate a treatment plan and its immediate implementation. Now coming to the vena cava filters. So what is the aim of this vena cava filters is that to mechanically prevent the venous clots from reaching the pulmonary circulation, especially the lower limb DVT. So it is inserted percutaneously and it can be retrieved after several weeks or months, or it can be left in place over the long term if needed. So it is divided as retrieval IVC filters and permanent IVC filters. So what are the potential indications? This they will ask in your exams, especially the practical exams. So VTE, there is a presence of VTE and there is absolute contraindication to anticoagulant treatment. The second one is recurrent PE despite adequate anticoagulation. The third one is, this is a little bit questionable thing, primary prophylaxis in patients with high risk of VTE. Fourth one is if you're finding any free floating thrombi. There are a lot of studies which have been done on this IVC filters. I'll discuss it later. So this one is very important for you. So any patient with acute PE, you first anticoagulate the patient and then see if the patient is hemodynamically stable or unstable. If the patient is hemodynamically unstable, he is a high risk PE. So you have to do immediate reperfusion treatment. And if any hemodynamic support is required in the form of VA ECMO, you have to give it. Then if the patient is not hemodynamically unstable, then you have to check two things. Okay. One is the PACE scoring and the other is RV dysfunction. Okay. If one or two, both are present, you have to perform the troponin test and then divide this patient into intermediate high risk and intermediate low risk. Okay. And if none of them are present, then it is a low probability or low risk PE where you can actually, nothing much has to be done about the treatment part. So this is the one which we actually discussed, but in a flowchart form. And this is about the proper treatment. How do you do it? So acute PE, we anticoagulate the patient, see for the hemodynamic instability. If yes, as I told, it is high risk PE, also known as massive PE. Okay, then you think whether you can thrombolize this patient, see for the contraindications. If there are any absolute contraindications, you consider either the surgical embolectomy or the catheter directed thrombolysis or any other form of catheter directed treatments. If there is a relative contraindication, you can consider the catheter directed thrombolysis, or you can give a reduced dose of systemic thrombolysis. And if there are no contraindications, you can give the full dose of systemic thrombolysis. After this, if any patient is having a refractory shock or a clinical decompensation or cardiac arrest, as I told, you can consider the mechanical circulatory devices or mechanical support. So this is about hemodynamically unstable patient. Now, if the patient is not hemodynamically unstable, then you have but there is a positive PESI, there is raised troponins and or BNP, then you divide the patient into intermediate risk patient and a low risk patient. For an intermediate risk patient, the intermediate risk PE is known as submassive PE. So here, in submassive PE, as I told, there is no hemodynamic instability, but there could be either a RB abnormality or a rise in troponin or BNP, okay, which is known as intermediate high risk PE. Whereas if any one of them is positive, then it is intermediate low risk PE, for which you can give anticoagulation. But for intermediate high risk PE, you have to think about whether to thrombolize this patient or not. So if there are no absolute contraindications, then you can use a catheter directed thrombolysis or reduced dose systemic thrombolysis. And if there are absolute contraindications, same as I told previously, consider catheter or surgical embolectomy. Okay. Now the important thing is about this thrombolysis. So there were a lot of studies which have been done for submassive high risk PE thrombolysis, whether thrombolysis is really beneficial or whether it is very much detrimental. So there are a lot of studies which happened. So you people have to go in detail about these studies. This is just an overview which we are giving it. So in 2002, you have the MAPET-3 trial, followed by some TIPIS trial, MOPET trial, TOPCO trial. All these trials showed that basically they have given either altiplase or tenecteplase with heparin. This is one group, and the other group would be either heparin plus placebo or plain heparin. So they have seen that in all these, actually the above 4-1, they have showed that they have reached the primary endpoint was a positive one in case of heparin plus a thrombolytic agent. Okay, and the chances, the adverse effects were also less. But when in 2014, the PITHO trial has come. Okay, so this showed that the death or hemodynamic, basically the primary endpoint was death or hemodynamic decompensation within 7 days after randomization. So what they have seen is there was no statistical difference between the two, but they saw that the extracranial bleeding manifestation occurred in 32 patients in tenecteplase group, whereas it's only just 6 patients in placebo group, and it was statistically significant. Also, they have seen in stroke, that is the IC bleed have occurred in 12 patients in tenecteplase group versus only 1 patient in placebo group. So before this, everyone were giving, thrombolysis, IV thrombolysis for submassive PE. But after this trial, there was a lot of discrepancy of giving this thrombolysis in submassive PE. So later, they have actually seen a lot of studies have happened, and they came with a new concept of half dose thrombolysis. That is altiplase around 50 mg. We would give 100 mg, right? So this is only 50 mg over 2 hours. So they have performed a lot of studies. Some studies showed some positive efficacy, whereas the other studies show some negative efficacy. So still there remains a lot of unclear concepts and with respect to both efficacy and safety. So there is one trial which is still ongoing. That is nothing but the PITHO-3 trial. Okay, this was actually, the randomization has been done in 2022. The trial is still ongoing. So basically, this has shown the half dose thrombolysis, whether it is beneficial or not beneficial. So the results are still awaited. So we'll see when we are going to get those results. So PITHO-1 is basically about submass thrombolysis, full dose thrombolysis in submassive high-risk PE. PETO 3 is for half-dose thrombolysis in submassive PE. So if anyone knows what is PETO 2 trial, please put it in the chat box. Now next come, this is the trials for the IVC filter. So we have two trials, the PREPIC 1 trial and the PREPIC 2 trial. The PREPIC 1 trial actually is nothing but the prevention of recurrent pulmonary embolism by vena cava interruption. So they have done, this is for proximal DVT. They have used anticoagulation plus IVC and anticoagulation, plain anticoagulation. So here they have used a permanent IVC filter. And they have seen that there is significant reduction in the risk of recurrent PE, but at the same time, there was a significant increase in the risk of DVT. Okay, so basically there was a null effect. So without a significant decrease in the risk of recurrent VTE or death. Now, what is this PREPIC 2 trial? So this is also same, the PE and venous thrombosis to receive anticoagulative treatment with or without a retrievable vena cava. They've used a temporary vena cava here. And the rate of recurrent VT was low in both groups. So there was not statistical difference in this. And this trial also showed that if anticoagulation is more than sufficient and for prevention of VTE, there is no requirement of any vena cava filter. Now, important thing is how long to anticoagulate these patients. So if there is a first episode of pulmonary embolism, or there is a VTE secondary to a major reversible risk factor, like an immobilization or a recent surgery trauma, then you can give the anticoagulation for 3 months. So when to give the extended or a 6 months therapy of anticoagulation if there is a recurrent VTE, okay, or any first episode of unprovoked thrombosis, okay, then you have to extend the anticoagulation for 6 months. Now, indefinite duration until in patients with any underlying thrombophilia disorders or a recurrent unprovoked episode of PE, or in patients with malignancy. So these are the same, the recommendations for patients without cancer, and this is for patients with cancer. I've just made it into a easy chart, which I've explained to you before. Now a short note on pulmonary embolism during pregnancy. So this is a very important topic because already pulmonary embolism is a most severe or a horrible thing. Upon that, a pregnant woman having this is unimaginable situation for us. So any patient with a suspected PE during pregnancy, you say divide them into high, intermediate or low probability test and do a D-dimer for them. And you have to anticoagulate them with low molecular weight heparin. Okay. And better to perform a compression ultrasound in these patients only if you want it diagnosis badly and the patient has crossed the first trimester of pregnancy, then only you can expose the patient to a chest x-ray. Otherwise, better to do a compression ultrasound. If there is an evidence of a proximal DVT, then you have to continue the no molecular weight at therapeutic dose. Then you have to assess the PE severity, then involve the multidisciplinary team, and then during the pregnancy, labor, and post-delivery, you have to alter the anticoagulation. Now, if there is no evidence of DVT, so the problem comes actually here. Proximal DVT not present, then you have to actually make the pregnant lady undergo a lot of tests. So then you do a chest x-ray. Okay. And if the chest x-ray is normal, you have to do either CTPA or a perfusion lung scan. Even if the chest x-ray is abnormal, you have to do a CTPA. So basically, you are actually putting a lot of radiation, exposing the patient to a lot of radiation if the patient doesn't have a proximal DVT. So, okay, you have done a CTPA. If it is negative, then you have ruled out the PE. If there is indeterminate or a positive, then you have to review it with a radiologist. And then if it is positive, you have to continue the same treatment. Now, coming to the evidence. So, as I told, see, this is the one. In a pregnant patient with suspected PE, particularly if she has symptoms of DVT, so venous cuff should be considered to avoid unnecessary radiation. This is 2A, class 2A. And if you want a perfusion scintigraphy or CTPA, this is important, with a low radiation dose protocol. It has to be discussed with the radiologist, should be considered to rule out suspected PE in pregnant women. And a CTPA should be considered as a first line option if the chest X-ray is abnormal. Now coming to the last topic, what is a long-term sequel of the pulmonary embolism? So in those patients who are PE survivors, majority of the patients, their pulmonary arterial blood will be restored, and actually no routine follow-up CTPA is required. But very few patients in whom the thrombi may become persistent and organized, leading to a complication known as CTEPH. So what is CTEPH? That is chronic thromboembolic pulmonary hypertension. So it is a potentially life-threatening obstructing vasculopathy, which is caused by persistent obstruction of the pulmonary arteries by organized thrombi, leading to flow redistribution and secondary remodeling of the pulmonary microvasculature bed. The incidence is 0.1 to 9.1% in the first 2 years after a symptomatic PE event. So this is a beautiful flowchart telling about the pathogenesis of CTEPH. So basically, in majority of the patients, there are more than 90% post and pulmonary PE event, there will be clot resolution. But in the remaining 5%, less than 5% patients, there will be incomplete thrombus resolution after 2 years. Okay. So this thrombus, there are the hypothesis which leads to the CTPH. What are those? The first hypothesis is due to increased hypercoagulability, which is associated with increased levels of factor VIII. The second hypothesis is due to impaired clot lysis. The third one is due to impaired angiogenesis. And the fourth one is because of some inflammatory thrombosis. So all this leads to fibrous deposition, leading to fibrothrombotic organization, causing some webs and bands, and this leads to slow blood flow, and this slow blood flow leads to clot formation, leading to branch occlusion, and this leads to some adaptive vascular remodeling, leading to progressive pulmonary hypertension. So what are the risk factors or the predisposing factors for CTPH? So one could be a patient having a previous episode of PE or DVT, or if they have a large pulmonary arterial thrombi on CTPA, the echocardiographic signs of PH or RV dysfunctions are present, and CTPA findings suggestive of pre-existing chronic thromboembolic disease. These are the patients who are predisposed to CTPH. So if there are any other concomitant chronic diseases, like any ventricular arterial shunts, any infected chronic IV lines or pacemakers, history of splenectomy, any thrombophilic disorders, hypothyroidism, any history of cancer or myeloproliferative disorders, these patients are more prone for CTPH. So how to diagnose this? So basically, you have diagnosed acute PE, you have put him on anticoagulation, you sent them home, and you call them for a follow-up at around 3 to 6 months. And you have to assess if the patient has any symptoms of dyspnea or any functional limitation. So if there is any dyspnea or functional limitation, you have to do a transthoracic echo and determine the probability of pulmonary hypertension. So whether it is a low category, low probability, intermediate probability, or high probability. So this is the risk stratification for PH of low, intermediate, and high category. So we have to see that. And if there is a low category, you have to see the alternative causes of dyspnea. But if there is an intermediate or a high category, you have to see these three things. One is the elevated NT-proBNP levels, any risk factors for CTPH, and if there are abnormal cardiopulmonary exercise testing results. If greater than 1 is present, then we have to perform a VQ scan and see if there is a mismatch. And if there is a mismatch, then you have to refer the patient for an expert center for further diagnostic workup. Okay. And if there is no functional disability, so you have to just focus on anticoagulation and secondary prophylaxis. So what is the treatment of CTPH? So there are three treatment modalities. One is the surgical pulmonary endarterectomy, which is the treatment of choice for operable CTPH. If the patient is inoperable, then you can do balloon pulmonary angioplasty. And you can also try some pharmacological treatments like anticoagulants, diuretics, and oxygen. Lifelong oral anticoagulation with BKs is recommended. And the only drug which is approved for inoperable CTPH or persistent or recurrent PH after pulmonary endarterectomy is the deoxyguan, which is nothing but an oral stimulator of soluble guanyl cyclase. So we already shared this. Please go through this ESC 2019 recommendations for PE. Thank you.
Thank you, ma'am. Audience, your questions will be answered if they're posted in the chat box as soon as possible. Okay. So if any questions you can still ask, you have a minute or so that you can also relax for some time. I think so. Dr. Dan has just typed it as R. I don't know. Or else we'll start with the next. Shall we go ahead with the next session then, without wasting further time? Is my screen visible?
Yes, sir, it is visible. Just
Okay.
put slideshow, sir,
Sure,
slideshow.
sure. Yeah. Okay. Good evening, everyone. I think so. After an extensive talk about pulmonary embolism, you guys have the basic idea as to how to approach a case in pulmonary embolism. So now to go to the next talk, which is more or less, something which is more practical. But having said that, there have been multiple questions which have been asked in the previous exams, be it FNB or DM. The next topic is ultrasound lung in critical care medicine. Okay, so the question bank which we went through had these questions which were asked in the previous years. Sorry. The first common question which was asked is lung ultrasound in ICU, which is from 2018 in FNB to PGIMER and DRNB. Even in 2023, they've asked a question called as lung ultrasound in ICU. So the other questions were like focus in critical care and add a note on blue protocol in DM 2019, assessment of diaphragmatic function using bedside ultrasound in DM 2018, and ventilator-induced diaphragmatic dysfunction in DRNB 2022. So the basic thing is whenever you get these questions, it's going to be a 5-marker question, if not a 10-marker. 10-marker usually would require you to write in depth, but that detail is not usually expected out of a candidate. And what they focus here is headings under what you want it. Okay, so if they've specifically asked the blue protocol, don't try and explain what is A line, B line, etc. Just start writing about blue line, make sure it is a flow chart, and then you answer to the specific point. Okay, it's very clear in DRNB and DM, they want the specific answer, and you will have a space restriction. So make sure that you write it in a heading format and make use of flowcharts as much as possible, especially in a practical aspect. Even in pulmonary embolism, you saw a lot of flowcharts. So make sure that you use that technique. Okay. So the role of ultrasound in ICU is, increasing by the day. The probable need for a stethoscope would go out of vogue in the next couple of years. So it's been more than 2 decades that ultrasound has been used in the ICU, and the use is increasing with the availability of the ultrasound in most of the centers right now. So ultrasound is used either for diagnostic purposes or either a therapeutic or an interventional based methods. So the spectrum of use from head to toe, there are multitudes of uses of an ultrasound. But this talk, I'm going to restrict only to the lung ultrasound. So what are the advantages of ultrasound? So whenever they ask you a question, you can add this in the end of your answer, like what is lung ultrasound? Write about the advantages of an ultrasound. The advantages of ultrasound, to name a few, are its portability, its repeatability, the risk of radiation being reduced, and the learning curve being relatively easier as compared to a CT or an MRI, and it being more cost effective. So these are the things which made the use of ultrasound in critical care rampant. So we all know, we have been using it day in and day out. These are the probes which we usually use. They are ranging from a low frequency probe to a high frequency probe. I'm not going to go delving much into the details of such probes. You need to know the higher frequency probes are used for a more superficial structures to get a refined image, probably for an intervention. And as we go deeper, we need to get a higher frequency, lower frequency, so that you get the depth analyzed properly. So these are the grayscale echogenicity, which usually is used in ultrasound. The echogenicities are usually classified as iso, hypo, or hyperechoic, or anechoic. So what we usually see in a lung ultrasound, what I would want you to know is hyperechoic structures, probably being the pleura, or a consolidation, or an anechoic structure like a pleural effusion. Okay, and hypoechoic structure being probably the diaphragm. Okay, these are the things that we need to understand in a lung ultrasound. So coming to the questions that we need to ask whenever they ask, if the question is asked lung ultrasound in ICU, what are the things that you need to write? First, you can write what are the probes used for a lung ultrasound, like what is the probe specifically used for a pleura? What is the probe that is for pleura? You usually use a linear probe. For a parenchyma, you use a curvilinear probe. So something like that. You can classify that question and write the answer accordingly. Then you need to write about the ideal position of a lung ultrasound. Then you need to explain about the scenarios in the lung ultrasound. Then you can go write about your blue protocol, your lung aeration score, etc., so on and so forth. Okay. So coming to the next question, let us keep it a little more, interactive. So can you guys, one of you unmute and answer what is this? So it's a lung ultrasound. We know that. So what do you see this? Is it a normal ultrasound or not? Please say yes or no, guys.
Yes.
It
Yeah.
is a normal. Yes, yes.
Okay. So one of you, I see Dr. Dinesh is unmuted. Dr. Dinesh, would you like to just name the structures from above to below? In one, either of them you can take, either the left or the right image.
Skin, subcutaneous tissue,
Very good.
intercostal muscles, two rib structures, and
Very
followed pleural line, and then underneath we have some A lines, reverberation artifacts.
awesome. Awesome. Great. Really good. Yeah. So this is a classical thing which you see in a linear probe. I think so. Dr. Dinesh extremely, clearly told the structures. So summing it up, as he told, subcutaneous fat, the muscle, the pleura, the ribs, the rib shadow, A lines. Awesome. If you write this much, I mean, this is what it is anticipated in a practical exam. Theory also, you just need to mention these things. Okay. So if you can make a rough image, if they ask you this also, would be great. Okay, in your answer sheet. So what are A lines basically? Dr. Dinesh actually beautifully told, it's a reverberation artifact. You usually see it in a normal lung, which is a good aerated lung, right? Nothing but the ultrasonic waves which are reflected back to the probe. That means to say there is no pathology underneath, and it is the normal lung structure which is going to get reflected back into the probe, which is seen as this grayscale image. Okay, so here we can see the pleural line, which is a little thickened. So always be very clear about this. When you see a hyperechoic line, that is the pleura or a peritoneum. Usually these are hyperechoic. And when you see the other lines, which are there horizontally present lower down, and they are repetitive. So these are called as the A lines, which are usually a reverberation artifact in the ultrasound. So we have already spoken about these. This is the linear and the curvilinear probe. Okay, so there are two types of scan which is usually approached in a patient who needs a lung ultrasound. Either it can be a longitudinal type, where we go in multiple intercostal spaces. We usually start from anteriorly towards the manubrium and go in a lateral fashion, so in which we cover most of the lung of that particular zone. Otherwise, if you're looking at a particular intercostal space, say suppose you have a consolidation and you want to have some more idea about what pathology is happening, then you use an oblique scan. Okay. So what are the surface landmarks which are usually divided into? All There are multiple studies which have been done on lung ultrasound. The most important one, which the markings have been noted down, is first you need to make the ideal position for a patient to get lung ultrasound would be in a supine position. okay, and in which the hand is extended out, axilla is exposed, and you need to draw two lines that is vertical, that is the anterior axillary line and the posterior axillary line. And then after that, a horizontal line is drawn from the nipple areal or complex, both anteriorly as well as posteriorly. Okay, so this usually divides the lung anteriorly and laterally into 4 zones. That is what you see in the picture, 1, 2, 3, and 4. Similarly, if you extend the same line, the horizontal line posteriorly, and you draw a line in the spinous process, that again divides the posterior part of the lung into 2 more zones, that is 5 and 6. So usually when you see any surface landmark for a lung, on each hemithorax, it is usually divided into 6 zones. Okay, so totally there are 12 zones that we need to scan in any lung ultrasound. Okay, I hope I have made it clear. Okay, so coming to the normal lung ultrasound. Okay, so as we have seen previously in the linear image as well as in the curvilinear image, you see there is two ribs which have their shadow, and you can see anechoic picture below the ribs, as well as the lung parenchyma which is present. So this is called the bat wing appearance of the normal ultrasound. Okay, so usually what you see if nothing is present is the A lines, as we have already discussed. So what is this, guys? On the left-hand side first. What do you see?
Lung sliding.
Very good. So this is a normal lung slide. Okay, this is what we expect you to know in a practical exam. So this is the next part of a normal lung scan. Okay, this is one of the primary things in any protocol. If you take the blue protocol or any other lung ultrasound, they start with the normal lung slide, if it is present or not. Okay, so as you can see here, the parietal and the visceral pleura, you see marching of ant sign or the lung sign. This is what a lung slide is, what usually is seen. And when you put a M mode, what is seen here? What is this called on the right side?
Seashore sign.
Very good. A seashore sign. As you can see, it's clearly labeled. There is an ocean and then you have a sand on the beach. So when you see the movement, the M mode presents a seashore sign. This is something which we see in a normal lung ultrasound. Okay. So coming to the abnormal lung ultrasound lines. Okay. So we are going to start with those right now. So all of you would be hearing about B lines, right? So what are B lines? One of you unmute, please. Okay. So I'll make it less this thing cumbersome. I think so. B lines are something that is an abnormal line. Okay. Usually they are vertical lines. They arise from the subpleural space and they go vertically downwards. How do you differentiate between a B line and a Z line? What is a Z line? Now I want you to unmute and answer.
Subacute emphysema.
Okay, that is called an E line. Okay, that is an answer. That is something which I will accept, but it is not the right answer. Okay, that is an E line. So there are something called as abnormal B lines. Okay, what is the main characteristic of a B line?
Starts from the pleura and extends till the end of the screen.
Screen. Okay, done.
It is
Anything
more
else?
than 3 comet tail artifacts will be seen.
Very good. Okay. The most important thing we are missing. See, it has to cut through an A line. You should never see an A line. Okay. If you see that it is, cutting across or it is getting breached by an A line, that is not a B line. Okay. So this is what becomes, a little more difficult if you're not doing it on a day-to-day basis. You might get confused. Whenever you see some Z lines, you might think that it is a B line. Z lines are usually seen in patients who have some amount of air accumulation, like one of you previously told, right? Like an emphysema or a hyperinflation. In such cases, you would see a Z line. Okay. So coming to these things. So you see here, you in the image labeled C, you can see a line which is vertical starting from the subpleural space, but you can see it is breached by an A line, correct? So these are Z lines. So these usually do not indicate a pathology. It can be a confounder. Okay. So coming to B lines, as you guys have already spoken beautifully earlier about lung rockets and a comet tail artifact. So what is usually a lung rocket? So you see multiple B lines which are interspaced in a single intercostal space between the two ribs, the width between them being less than 7 and the lines more than 3. Okay, so usually if you get these things, it is indicative of a lung rocket. So B lines usually they can appear as single, double, or 3. So usually more than 3 B lines is something which is significant of a subpleural interstitial edema. So B lines, you should understand that it is interstitial edema. Okay, so the B lines are what you have to mention about the origin and extent of those lines. Okay, and then what are the pseudo B lines? And then what does the B line indicate? These are the 3 things which you have to write down when you write the answer in lung ultrasound. Okay.
What
So
does that lung rocket indicate, sir?
so lung rockets is the number of B lines. So usually you need to tell that the interstitial edema is more. Probably you need to think about the cause of it. If you see a consolidation in that picture, probably it is because of a pneumonia. If you see no consolidation, then you need to look at the other causes of interstitial edema, probably a cardiac cause. So the number of B lines or lung rockets indicates the amount of interstitial edema present in that particular space. Okay. So coming to interstitial syndrome. So you might have heard this terminology also being used. As I've already told you, presence of more than 3 or equal to 3 B lines per rib interspace is something which you need to get worried about. That is, it is showing the presence of more amount of interstitial edema. If that B pattern is present in more than 2 lung zones bilaterally, so I told you there are 12 lung zones totally, right? Each like 6 on each hemithorax. If you see like that, if you have more than 2 lung zones bilaterally, then it is indicative of interstitial syndrome. Roughly, you should say it is 4. Okay, but it has to be bilateral. That is very important. Only then it is called interstitial syndrome. So interstitial syndrome, usually if you have an interstitial syndrome, very rarely it can be a pneumonia. It can still be pneumonia, but when you have interstitial syndrome, think about the possibility of a cardiogenic origin of pulmonary edema. Okay. So these are other images which you need to mention when you write about the lung ultrasound answer, theoretically speaking. Okay, so you have to finish about the normal lung lines, then you have to write about the abnormal lung lines, then you have to write about the other structures which are visualized. So you start from one end and go downwards. Okay, so the other thing which you need to write is about PLAPS points. Can anyone expand PLAPS? I'll ask it later on, but if you can tell it now, I'll skip it.
Posterior lateral alveolar pleural syndrome.
Very good. Okay, so that is the apt definition of PLAPS. So usually you have a left PLAPS and the right PLAPS. Okay, so the structures which are visualized in these PLAPS point is something which will give us a lot of idea, right from pleural effusion, the movement of the diaphragm, or any other pathology. Okay, will be seen in PLAPS point. Then what is the most important thing that we are looking at when we do a PLAPS test?
So consolidation or pleural fluid?
Very good.
Very good.
Okay. That is the thing we want to know. Pleural effusion and consolidation. These 2 things are the things which are necessary to be ruled out when we do a PLAPS. So whenever you write your usual, I hope all of you have a lung ultrasound scheme which you write, and that we need to write this. Okay. So coming to the specific pathologies in lung ultrasound, these are the things which we'll go through. We've already spoken about interstitial syndrome, coming to pneumothorax, consolidation, and pleural effusion. Okay. So pneumothorax. So we all know that. I said it clearly in the earlier slide on lung sliding. So we start with lung sliding. Lung sliding is something that is very important to know. Okay. Can you have, is there any thing that we need to see along with this to rule out pneumothorax? Probably if you have a normal lung slide or an abnormal lung slide, but you have something else that rules out pneumothorax, it's actually there in the slide.
Venous.
Correct.
B-line.
Okay, that is the most practical point. All the seniors or all the people who do lung ultrasound tell us, right? So the probability of a pneumothorax comes down if you have a B line which is present, even though there is absent lung slide. Okay, so start with lung sliding. If there is lung sliding, pneumothorax is usually ruled out unless it is a small one. Okay, so if it's a small one, probably we need to do a CT. Okay, if there is absent lung sliding, then look at the presence of B lines. If there is B lines, still there is a possibility that pneumothorax might be absent. Okay, then you need to look at the presence or absence of A lines. If there are no, if there is absent lung sliding, but if you have A lines, then you need to find out the lung point. So can anyone tell what the lung point is? Okay, the lung point is actually the point in the lung ultrasound, which is the junction between the normal lung as well as the point where the pneumothorax is started. Okay, if you just move the cursor from the M mode slightly away from the lung point, you will see a normal seashore sign. As soon as you move it towards the pneumothorax area, you will see a stratosphere or a barcode sign. Okay, so that is the point in which the seashore sign changes to a stratosphere sign is called the lung point. Okay, it's a junction between the normal lung and the abnormal lung. So it is actually a lung point pathognomonic, or if you see a lung point, can you think about this thing, pneumothorax? Most likely the accuracy is around 95%. Okay, there are 5% chances that it might not be pneumothorax as well. Okay, there are certain situations where you will not see. So that comes to another question. So you will have what are the conditions in which you see a barcode or a stratosphere sign, but it is not pneumothorax? What are the differential diagnoses?
Endobronchial intubation.
I'll come to that. Probably, yeah, it's there, but yes, I don't think so. There will be a lung point there. Mm, Difficult. Maybe anything else? Sorry, collapse. Maybe yes, one of the reasons. Can you just modify your endobronchial intubation? So there is severe hyperinflation, right? Whenever you have severe hyperinflation in endobronchial intubation, you'll see this. Okay, so that is one of the things. If there are pleural adhesions, like severe consolidation, that time you can see a barcode sign. And even in patients who have emphysematis bullae, even they can have a barcode sign. Okay, these are the things where you can get misled. Okay, that is the reason why ultrasound is still not the gold standard for pneumothorax. Okay, these are the drawbacks. So you can write this as one of the drawbacks of lung ultrasound. Okay, so is this clear? Lung sliding, presence of B lines or absence of B lines, A lines, lung point, then you have to have the differentials. Okay, if there is no lung point, still don't tell that there is no pneumothorax. Okay, probably ask for a X-ray or get a CT based on the stability of the patient. Okay, so can you see the absent lung slide here? See, you don't see that marching of ants, right? So that is one thing which is important. So here there are the signs which we see. You see on the left side, you see a seashore sign. Then it gets converted to this whole sandy appearance is lost into a stratosphere or a barcode sign. Okay. So in 2012, there was an international consensus conference recommendations which said if these four sonographic signs present, the diagnosis is more or less accurate. Okay. That is, it has to go in an order: absence of lung sliding, absence of B lines, absence of a lung pulse, and presence of a lung point. So the next question, I think so most of you would have guessed what is a lung pulse. Can anyone tell you? I mean, just unmute. Okay, I'll not waste further time. So what happens is when you have a lung pulse is actually an abnormal finding when you have conditions like an endobronchial intubation or a subpleural pneumonia or an atelectasis. Usually what happens when that particular part of the lung is not moving, if it is very close to the heart. So what happens? The cardiac oscillations get transmitted, and that can be seen in a pulsatile manner. Okay, that is called as a lung pulse. So usually you have to rule out these confounders when you come to a diagnosis of pneumothorax. So I'll repeat it again. In case of a hyperinflated state, like mentioned earlier, you have to rule out endobronchial intubation. When you have the pleural line, when you see it on an M mode, if you see there are oscillations which are seen, so that is usually a cardiac transmitted oscillation, mainly because of endobronchial intubation and hyperinflation, and it is not a case of pneumothorax. Okay. Is it clear? Okay. So what are the diagnostic accuracies when we see a patient with pneumothorax? So first, we have spoken about lung sliding. So it is almost 100% accurate. But B lines in comet tail and lung point, again, you see that no sliding and lung point is 100% specific. But the sensitivity is something which is worrisome. In 66% of patients only, people were able to pick it up. That is, we cannot find that, a zone where you have the normal and the abnormal lung point. So that is the reason the sensitivity is low, but the specificity is as high as 100%. Okay. So whenever they have combined the both, the sensitivity increased to up to 100%, and the specificity was also great up to a 96%. Okay. So interstitial syndrome, I've already discussed. More than presence of 2B profiles in each lung zone bilaterally would usually lead to an alveolar interstitial syndrome. So usually, which is seen in patients with consolidations. Okay, so consolidation usually depends on the type or the progression of pneumonia. It can be anywhere. The worst case scenario would be hepatization of the lung. Otherwise, you usually see like a tissue-like picture in the lung ultrasound. So whenever you have a diffuse interstitial fibrosis, which is set in a case of an ILD, we were talking about comet tails and pneumonia, we were talking about consolidation. But when you see an interstitial fibrosis picture in an ILD lung, a patient with any rheumatological condition, spread to the lung, then you can see a diffuse interstitial fibrosis comet tail. Here, usually, as I've mentioned before, the comet tail artifacts are usually 7 millimeters apart. Okay, so whenever you have a confluential B line picture which is spread across, better think about the possibility of interstitial syndrome. You can always confirm this pattern on an X-ray, and then you can probably think for the need of a CT to further evaluate your case. So this is what you need to think about when you have a confluent B lines within widely spaced B lines. So how do the progression of a consolidation look like in an ultrasound image? So this is one more thing. If you can put a flow chart in your answer when they ask lung ultrasound, is usually it starts with multiple B lines earlier in the case. So you have a patient who just walked into the ICU. I mean, wheeled into your ICU with pneumonia, LRTI. You've diagnosed, and you just did a lung ultrasound. You initially find some multiple B lines, probably a consolidation. Okay, that would, if not treated appropriately, would lead to a confluent B lines subpleural consolidation. You might look at shreds also. If these things are not addressed at the right time, probably the patient can end up in a dense consolidation. And the ultimate thing, what we would look in a lung ultrasound is a hepatization of the lung. Okay. So this is one thing you can, for theoretical purposes, I thought this slide would help you guys. Okay. So we already spoke about PLABS. So this is where you usually see it. Okay. So the expansion of PLABS is posterolateral pleural syndrome. So you use for, as you guys have already mentioned earlier, consolidation as well as pleural effusion. So shred sign, can anyone tell what is shred sign? Okay, so shred sign is nothing but subpleural consolidations. Okay, it's clearly there in the screen. So what happens is they are more or less superficial type of consolidation, which are more closer to the pleura. So what happens in these scenario is, if at all you put a marker there and do M mode, you might not find the lung sliding, but it's clearly visible when you do this, that when you have the batwing appearance initially appearing, you see some amount of B lines initially, and then you see there's some hypoechoic structure there, right? So that is usually called as the shred sign. That is subpleural consolidation. So this is a classic lung ultrasound showing hepatization in the star mark. Okay. There is some amount of a thin rim of pleural fluid as well. So what is this? It's already labeled as an air bronchogram, so that's not this thing. What type of an air bronchogram is this?
Dynamic.
Very dynamic. Very good. Where do you see a dynamic air bronchogram? So you mostly see it in
In
consolidation.
consolidation.
Very good.
Consolidation.
Okay, so you need to roll out air bronchograms are basically helping us to rule out between atelectasis as well as consolidations, right? So the homework question I think so would be to tell the types of dynamic air bronchogram. Okay, there are types of dynamic air bronchograms. I would like you guys to go up and read about that. Okay, so that would be a brownie point if you can answer and write those in your exams. So that is one thing. Okay, so in Plapp's point, there's another thing which we are looking at apart from consolidation, that being the effusion, right? So usually you will be able to look at these things given what the side you're looking, either it's the right Plaps or the left Plaps. In the right Plaps, the structures which need to be analyzed are the diaphragm, the lung. Okay, along with that, the structures which confirm that it is the right Plaps are the liver and the right kidney. Okay, so can you label? I mean, tell me what sign is this? This is quick, okay, because we need to answer a few more other questions. Lung ultrasound is almost done, okay? It's called a hematocrit sign, okay? So you can see that there is some amount of hyperechogenicity in a pool of anechoic fluid, right? So when you see a hyperechogenicity in a pool of hypoechoic structure, that usually involves a hematocrit sign. So where do you see a hematocrit sign? What do you worry? So you have a patient with trauma coming in, you see this hemothorax. Yeah. So this is something that you need to, so whenever they write a question of lung ultrasound, please don't write only about pulmonary pathologies, okay? Please think broader. You need to think about other conditions where you use lung ultrasound, okay? Please write about all the other places where you use. Don't stick to your answer and write blue protocol and be done with it, okay? The blue protocol definitely will pass you, okay? But the thing is the complete understanding that you might have to have. So you can write about other things like other than pulmonary pathologies. Okay, so these things will usually help you gain more marks. What is this? I'm sorry, I put that. Okay, it's called a sign. Yeah, good. So what you can see is there is some amount of collection in the subpleural space, right? It is very earlier signs which you see mild fusion. Okay, so this is the quad sign and the jellyfish sign. Okay, so having said all of this, is there any formula or method that we can quantify an effusion? I hope you guys are doing it day in and day out. There are multiple formulas. Okay, I'm not going to waste time. There are formulas like Balix formula, Gokey's formula. Okay, the most commonly used and the simplest one is the Balix formula. What usually Balix formula says is when you use the lung ultrasound in the Plapp's point, either right or left, okay, you need to measure a craniocaudal extension of the fluid. Say, suppose you're using this particular lung ultrasound, you need to measure it from this distance to this, okay, in a craniocaudal fashion, okay? That would be measured in millimeters, right? So you multiply that into 20 and the volume which comes out of it will be in ml, okay? So that usually quantifies the amount of pleural fluid which is collected there, okay? So that is Balix formula. There are multiple other formulas which, see, it will not give you an accurate measurement, but almost, a gross assessment would be sufficient enough to prove whether it is mild, moderate, or severe pleural effusion. Okay. So coming to the important, profiles which are seen in the Brew protocol, I've already mentioned few earlier, right? We've already taken pneumothorax as our main thing. So these are the profiles which are usually seen. So I initially want you to understand what each profile is, okay? So when you talk about A profile in blue, it is anterior lung sliding plus A lines plus free veins, okay? This is something that you need to write. Most of us, end the answer with lung sliding and A lines. We forget to write about free veins. What do they mean by free veins? Usually we have to look out for presence of any congestion or a clot, okay, either in the femorals or even in the superficial veins of the neck, okay? So whenever you see the bulged veins, probably they are an indication of exacerbated COPD or severe acute asthma, okay? So these are the things that you need to look at, and this constitutes an A profile. A B profile usually involves anterior lung sliding plus lung rockets, which says about interstitial fluid. It usually indicates pulmonary edema. B dash profile, AB profile, C profile, or AV Plaps profile. So B profile is presence of B lines with an abolished lung sliding. AB profile is a half A profile at one lung and half B profile at another point. So depends on where the consolidation is. Okay. Usually C profile involves anterior lung consolidations, which probably might not have enough B lines to start with. An AV PLAPS profile usually consists of A profile, free veins, and PLAPS point, usually which can show a presence of fluid. So all these are indicators of pneumonia. Okay. A DVT profile is usually consisting of A profile along with a proper DVT scan. That is usually a 4-point compression ultrasound test. Is usually done in case of pulmonary embolism. A dash profile is usually used to, speak about pneumothorax. So don't get confused between A profile and an A dash profile. A dash profile is A profile with abolished lung sliding with the presence of a lung point. So that is an indication for pneumothorax. So if at all you get a patient in your ICU, probable, a history of trauma, the case has been wheeled into the ICU, and then you're seeing some amount of desaturation, probably patient is even hypotensive, you're rushing some saline. So how will you rule out certain causes? Okay. So probably your ER resident would have, someone wants to tell something? Okay, so you can start with your EFAS, which usually tells out any major, issues with your pipes, pump, or the tank. And after that, we go ahead with the blue protocol. So in the blue protocol, you can do the lung sliding. You can, based on lung sliding, if it is present or abolished, we need to think what is the appropriate picture. If you have a B profile, usually it is indicative of pulmonary edema. If it is abolished, then you need to think about a B dash profile or an A dash profile. So if it is a B dash profile, it is presence of pneumonia. If it's an A dash profile, again, look at the presence of a lung point. Lung point is present, A dash profile, no lung sliding, 100%. It is of pneumothorax. But if you have a doubt and you've not got your lung point, probably you have to think about other things, especially if you see a lung pulse, etc. Then you probably have to rule out the possibility of a pneumothorax. Okay. If you see lung sliding and you see an A profile, then you look at the possible causes. Okay. Look at the veins. If there are free veins, then you can look at the PLAPS point. If there's PLAPS point showing some amount of fluid consolidation, then it is pneumonia. If there is no PLAPS point, then it's possibility of a COPD or an asthma. But if you see lung sliding, then you see there is an A profile, and then you see there is some amount of hemodynamic compromise, and you do a 4-point compression analysis, then you probably have seen a thrombosed vein, and then it might indicate the possibility of a pulmonary embolism. Okay. So the average, the overall accuracy, in spite of going so systematically, is only shown to be around 90%. Okay. So that's the reason still we cannot tell lung ultrasound is the gold standard to get all the diagnosis. Okay. So can anyone do a quick answer so that even I can rest in between? So match the following. A profile.
Normal lung.
Okay.
Okay.
You can
You
see
can
it.
see it.
Okay. Then
Okay. Then
A dash.
A dash. Pneumothorax.
Very good. B
Very
profile.
good. B profile. Pulmonary edema.
Very good.
Very good.
A, B, and
A, B,
B.
and B.
Pneumonia.
Pneumonia.
Okay, great.
Okay, great.
Okay. So the next important thing is, so we have come to all of this, majority of the lung is done. So the next practical question, which we are anticipating in the next exam, would be use of lung ultrasound and weaning. Okay. So this involves a lot of parameters which has to go in sync. So what are the tools which are used in the assessment of liberation from mechanical ventilation and lung ultrasound is what we are anticipating in the next exams. Okay. So can anyone tell what are the tools used for assessment of mechanical ventilation using lung ultrasound? Okay, identify these things then.
Diaphragmatic excursion.
Very good. One of them is diaphragmatic assessment. Then what do you see below?
Lung score. Lung injury score.
Lung aeration score. Very good. Okay, so these are the things which are usually used. Okay. Okay, I'll be really impressed if you guys can tell what other things are used along with this in weaning. One more parameter.
Thickening fraction.
Look away from the lung. That is what I would like to say.
Heart.
Heart, very good. Okay. So there's, when you're thinking about weaning, we need to look at the heart as well. Okay. That is one of the major things. So coming to the question of what is lung aeration score, does anyone use this quite use, So, okay. Usually, we discussed earlier, right? There are 12 zones which we have, divided the lung into for an ultrasound assessment. So, based on this, whenever we think that the patient is fit for extubation, we can, reassess this patient prior to extubating. Having said this, you need to do all the basic, assessment of weaning before you just do an ultrasound. Okay, it can't be that we skipped all the other parameters and just did a lung ultrasound and extubated the patient. Okay, you need to assess the patient for using all the other indices, then use a lung aeration score and an ultrasound assessment for best possible results. Okay, so what we usually see in a lung aeration score is you have 12 zones, 6 on each side, and based on the scoring system, here you see 0 means there is a normal A profile, right? It's a normal pattern. A score 1 indicates moderate loss of aeration. That is, there's still good amount of good lung tissue which is present. Probably the patients can still get better. So how do we tell that it is moderate aeration? That is usually less than 50% of the screen is without any subpleural alterations, or whatever B lines are there. Usually it will be 3 or less than 3. Okay, so if it is that, we give it a score of 1. If you see more than 50% of the screen being involved with multiple B lines or a coalesced B lines, okay, that time you need to give it a score of 2. When it is score of 3, you see a tissue-like pattern or a air bronchograms being present or a consolidation which is seen. So if you see that, then definitely that is the possibility of a score 3. Okay, so you need to do this in each zone. So what will be the whole score? So roughly we told about 6 plus 6, that is 12, right?
Yes.
12, then score 3 on each
Yes.
side if we give. So each side will get roughly around 18. Right hemithorax, left thorax. So the score ranges between 0 to 36. Okay, so
So that scan
this
is
is
done in the in between the ribs, sir. None of the pictures show the ribs.
See, what I clearly told you earlier as well, it can be done in between the ribs as well. The whole thing is we need to know what is the, if you do it in between the ribs or if you do it for that particular intercostal space, you will get the same picture, right?
Yes, sir.
So that doesn't change. So the nomenclature doesn't change.
Okay.
The whole thing is about the nomenclature. So because of all these issues, right, if you read the latest ESICM guidelines, so there was a lot of issues and talk between how trainees and experts who have been doing have labeled this. So because they wanted to remove all these arbitrary issues, they have made it very simple. Okay, this is, I think so, in 21 or 20. So after COVID is when they, thought that there's enough data in lung ultrasound to label it. So this is the simple one. So what I mean to say is, either ways, you have the same type of understanding. You have to look at the presence of B lines. You have to look at the amount of, the screen which is involved or the consolidation which is present. Okay, that anyways gives you the same score.
Thank
So you can see this picture, it will help you to understand better, I think so. Okay, you see this is usually what we use. Okay, you use a right lung and the left lung scoring. You see that anterior chest wall, lateral wall, and the posterolateral wall. Like I said, you're right, you need to have the anterior axillary line, posterior axillary line, then draw a horizontal line from the nipple and then divide it again. So you get all these zones, that is the 6 zone on each side. So together 12 zones, that is again divided into these zones. So when you have this marked between 0, 1, 2, and 3. So then you need to do a summation. If you do a summation and your patient has passed the SBT, okay, after the passing of SBT, you do a lung ultrasound. And if you find the lung aeration score is less than 13, probably the patient, can be successfully extubated without the possibility of a reintubation. But on the other hand, if you see if a lung aeration score is more than 17, it's been predicted that the extubation failure is very high. Okay, obviously these scans have been done more, and if I'm not wrong, the latest evidence on ultrasound also says that it gives around 90 to 95% probability of a successful this thing extubation if the lung aeration score is less than 11 to 13 is what the ballpark figure is. Okay, So coming to the assessment of the respiratory muscle ultrasound. So the other next important thing is the assessment of the diaphragm. Okay. So what are the tools used? How is the probe placed? What is the prerequisite? Okay. What are the adjunctive tools for weaning assessment? And what is wipe or wipe? What is wipe with respect to mechanical ventilation? So there's one question which I've asked, okay, that is weaning induced pulmonary edema. Okay, so you need to know this. I think so. The next session is on something, which will help you understand what happens in the cardiopulmonary system. Okay, when we extubate a patient. Okay, Dr. Bhuvana will be talking about that. So that explains the pathophysiology of wipe. So coming to diaphragmatic ultrasound. So whenever you have a patient, the ideal position is to keep them in supine position with a slight head end elevation up to a degree of 30. So if you give that, you might get a good zone of apposition. That is what you need to know. What is zone of apposition? It is the point. If you can see the image here, it's the place where you keep the transducer. Okay, this is the zone of apposition, wherein the diaphragm meets the thoracic cage. That is the definition of zone of apposition. The point where the diaphragm meets the thoracic cage is called the zone of apposition. So usually if you keep the probe at this position, you'll be able to assess the diaphragmatic functions. So again here, there are multiple ways that we need to look at. Both the probes are used. That is your linear probe and the curvilinear probe. So can anyone tell what are the things that we are looking at in the assessment of diaphragm?
Muscle area change, excursion.
Diaphragmatic thickness fraction and diaphragmatic excursion.
Beautiful. Okay, that is the most important thing we know. At this point in time, I would also want to ask, just to make it a little more interactive, is there anything else they're doing? Are you guys aware of other things that have been studied in lung? Diaphragmatic
Excursions.
excursion thickness fraction is one thing which has been
Excursion thickness fraction is one there.
Okay, apart from that?
Okay, apart from that?
Sorry?
Diaphragmatic
Louder, I can't hear you. Sorry. Okay, the other ones are tissue Doppler imaging, and then you have speckle pattern ultrasound. Okay, so these are the other things which have been actually currently in assessment, but there is no widespread data available for routine use in ICU. Okay, the biggest problem with diaphragmatic ultrasound is the learning curve. It's kind of difficult to get the images and then interpret based on that. Okay, so this is what you need to understand. So when you have the zone of apposition present, here what you need to understand is when it comes to diaphragm, you see this hypoechoic structure being here, or else here, this is a better image. You can see here, this whole thing, you see A, which is marked here, is the diaphragm. Okay. There is one hyperechoic line here, one hypoechoic line here. This is the pleura, this is the peritoneum. Then we need to also know there is one fibrous layer here. This is actually the neurovascular bundle. So the whole thickness is the diaphragm. This is what we need to measure when we are doing an assessment of the diaphragm. So always when we want this is ideally seen in the zone of apposition. Otherwise, we usually tend to miss one of the other thing. Either we miss the pleura or we miss the peritoneum. Okay, that should not happen. So ideally, we need to have some amount of liver if it is in the right side, and the left side, the spleen also comes into picture. Okay. So there are two probes which are supposed to be used, the linear probe and the convex or the curvilinear probe. So the linear probe is usually used for diaphragmatic thickness assessment, and the excursion is usually what we use, the convex probe. Okay. So coming to the diaphragmatic excursion. So what we need to do here is we need to understand the landmarks in which the diaphragmatic excursion is measured. It is usually in between the midclavicular line and the anterior axillary line. The patient has to be supine, okay, and the probe has to be placed in the subcostal margin. Okay, so when you place the probe in the subcostal margin, start from the midclavicular line and pass towards the anterior axillary line. Okay, and once you get the zone of apposition, then you can do the assessment of the diaphragm. Okay, so whenever you do this, you can usually see three sorts of things which are being present. So you can actually see if the patient is conscious, right? You can ask them to do a certain evaluation so that you have an understanding of the diaphragm. So this is the diaphragmatic excursion, that is the QB, which is usually seen in a normal quiet breathing.